I want to talk about one more sort of emerging area, and this is what we call precision medicine. When I think about it, it's immunotherapy, it's precision medicine are two big things. And talk a little bit, maybe Cathy, I'll start with you and say, so, should all these patients, if they have good performance status, there's tissue available, should we be doing broad profiling on all these patients?
I definitely think so.
Should the government pay for it? Should Medicare pay for it?
I think it's very reasonable for a metastatic patient if it's not been done previously, definitely. I mean, we
There's
need
all
to
this
look
fight
at other
about
options.
is it research or is it standard of care? And we all order Chem 20s, and a lot of that's kind of just fiddling and seeing. But is that?
I mean, we're looking for targetable mutations, and so that's the only way you're going to identify them. And we have to take the information that we have if it's available. And if it's not available, we really need to pursue it. Otherwise, we have very few treatment options for patients, especially since so many of the new drugs are very, very specific.
Yeah, we're really in this interesting space of companies doing molecular profiling, even our own shops, and yet they're doing it without making any money. They're hoping that this will become standard and appropriate. Everybody vote for it should be done, even though we're doing 500 genes and maybe one of them, and we all get P53 mutations. Is that worth getting back? What do you think?
Well, I think it's the raw data also, because that's something that we can go back and learn from. So if we can start to create these data sets of broad-based molecular profiling over broad populations, then maybe we can start to pull something out as we start to learn more about how these patients may respond to new drugs that are coming out. The other big issue, and you've mentioned it and done some very good work with it, is longitudinal biopsies. How are these cancers changing over time? And certainly we're seeing more targetable genes that are starting to appear as mutations later on in the course of the cancer across multiple different tumor types.
And we're seeing mixed responses. EGFR therapy, everything's responding with that MET. We biopsy that, and there's your RAS mutation all of a sudden. So the more we're doing, the more we're recognizing it's not static. Are we at where our lung cancer colleagues are yet? So molecular profiling, repeat biopsies, options, basket studies, this kind of thing. We have TAPER, we have MATCH, there's now Colamate that's emerging. Is this becoming a new way of drug development?
I'd like to believe that, but you pointed out, unfortunately, this isn't lung cancer. There aren't quite as many driver mutations that are detectable. And although you occasionally get very unusual ones you wouldn't expect, where do we go with those? We have to, if we don't have basket trials, we're very limited in how we can target them.
So it's becoming a very important way to go forward, even though it might not be the majority of patients. Anybody got a new favorite target? We talked about HER2. We talked about some of the immunomarkers. Let's do again the sort of, so we know about MSI, but PD-L1 we mentioned. What about tumor mutational burden? Tell me about that again.
So the thought is that the more mutations the tumor has, the more weirdo proteins it makes for the immune system to recognize. And so people in multiple different tumor types who have a higher tumor mutational burden, like MSI colon cancer, is a very high tumor mutational burden, tend to respond better to immunotherapies. Now, is that the end-all, be-all for deciding who's going to respond? No, but it would suggest that maybe that patient population may be more likely to respond. So there's some of the more rare, for instance, in colon cancer, there's some rare BRCA mutations that might result in an increased tumor mutational burden. Should we be looking at those folks? Cathy wrote an article on the polymerase epsilon as well that could be associated with potential response to immunotherapy. So now we have to dig down deeper and see what else we can find and pull out.
So this is just getting your opinions, because I don't think there's a right answer. So in the high tumor mutational burden patient, is it that there's a lot of mutations, lots of neoantigens, and that somehow stimulates the immune response? Or is it that if you have a lot of them, you're more likely to have the individual ones that are causing the stimulation? What do you think? It's a vote, it's a bet, right?
Okay.
Who knows what the right answer is?
So not all mutations lead to neoepitopes because it has to be able to fit within the HLA molecule of that particular patient. In fact, a lot of the mutations don't. So when we think we're, even in clinical trials, vaccinating against those mutations, we're really not achieving anything. It's going to be very individualized, which is why as precision medicine enters immunotherapy, trying to identify the neoepitopes in a particular person's tumor and create a vaccine or some other immune strategy targeting it becomes more important.
Yeah, that's, I think, maybe.
And those studies are going.
Yeah.
They're moving,
Dale, liquid biopsies. A lot of our people out there getting them. People are knocking on our door and saying we should be. What's your thought on that versus, say, tissue-based?
I mean, I think it's early. I mean, so, you know, we don't know with certainty what that's going to yield. I mean, I think that this is one of my peeves with a lot of our trials. We do a lot of biopsies that, you know, longitudinal biopsy, we can gain some information, but particularly in early phase trials, you know, we oftentimes show 400% inhibition of whatever we want to show, but we have no responses, right? And so if we can develop biopsy systems, liquid biopsies, that we can do that with less problems for the patients, perfect.
Yeah, I think the Colomate study's being designed in a way that does both liquid and tissue-based, so that'll be really the first database where those are both there, and I think will be very interesting. So using them as the standard approach, is there anybody doing liquid biopsy instead of tissue-based to determine some of these things?
No, not at this
Not yet.
time. And I have to say, in all honesty, we also are concerned about payment for liquid biopsies unless it's part of a clinical trial. That's another area of concern.